Michelle Johnston and I'm an emergency physician from Royal Perth Hospital. This is 5 on Friday and today's topic is the Glasgow Coma Scale. So once again, I'd like to talk to you about three things: the myths, the mastery and the misuse of this trauma scoring system. First myth is that the Glasgow Coma Scale was named after the Glasgow Kiss, a particularly brutal form of traumatic brain injury, but no. It was devised by two Glaswegian neurosurgeons in 1974, Teasdale and Jennett, and it was actually designed specifically to keep an eye on patients in a neurosurgical ward post-head injury. It was never designed to be a prognosticating scale, but that's how we use it. But if we talk about the mastery, that's the important thing. Now, you all know how to perform a Glasgow Coma score using a three-tiered system: eyes, verbal response, motor movement, 4 points, 5 points, 6 points. But here's where we segue into its misuse. Because these three subscales aren't equally weighted, a 2 in an eye is not worth a 2 in a verbal score or a 2 in a motor score. It's actually a bit of a fallacy to add them all together and expect that to be a really useful prognosticating score. This is why, to master the GCS, you need to add up the three separately, E1, V2, M3, however, and give the breakdown of the components. It's not a number that you just intuitively grab out of the air. It actually needs to be added up for it to have use. It needs to be performed with the best motor function and the best verbal response and eye-opening that you can get, and particularly if there's a hemiplegia, using the best side. It's interesting then when we come to some of the ways that we misuse the GCS. For example, you might have heard the aphorism GCS of 8 equals intubate. Not true at all. It's, as a general principle, it's quite a useful guide, but a GCS of 8 does not equal loss of airway reflexes. And so a GCS of 8 in one patient does not equal a GCS of 8 in another. As we talked about before with that ordinal score, when you add the numbers together, it can have very different prognosticating features in one patient versus another. It also shouldn't be used in a tox patient, although it does get used. It really has very little function to tell us anything apart from a very general decrease in conscious state in those patients. Because you imagine most of the scoring system is designed on head injury, particularly when you think about the motor scoring. This is the abnormal flexion, this is the abnormal extension. These are not things that you see in tox patients, and it was never designed to do that. So in summary, really the most important thing I wanted you to take away was that when you're scoring a Glasgow Coma score, you need to score the individual components. Yes, you add them together because that's how we understand it, but you need to understand what goes into it. So really that's all I wanted to say for you today. I've probably done less than 5 minutes. It saves more time for another. Thank you.